Hi, everybody. Thanks for being here tonight. My name's Megan McClean. I am the Cosmetic and Aesthetic Fellow at Gateway Laser Center in Salt Lake City, and I'll be joined tonight by my Fellowship Director, Mark Taylor. And tonight I'll be talking to you about upper blepharoplasty, specifically using the CO2 laser. So what we're going to talk about tonight is a brief review of the history. We'll discuss some of the indications for surgery, the reason why it's become the most common aesthetic surgery performed. We'll take a look at the anatomy and with a brief aside into some ethnic and gender variations. We'll discuss preoperative considerations and then get into surgical technique and complications with some tips along the way of how we try to avoid them. So a surgery to remove excess skin on the upper eyelids to improve vision was first described by Arabian surgeons in the 10th and 11th century. The term blepharoplasty was not coined until 1818 by Karl Ferdinand von Graeff, and it comes from Greek words blepharon for eyelids and plastikos to mold. The surgery has since then evolved and become the most commonly performed facial aesthetic surgery. When a patient comes into your office to discuss an upper blepharoplasty, some of their concerns might be aesthetic. They might tell you that they've got baggy eyes, they've got tired eyes, that they can't see their eyelashes to put on mascara, that they can't put any eye makeup on their upper eyelids. And you might notice when assessing them for Botox that they've got very strong forehead lines, that they get a little bit of a droop after some Botox. Those are all indications that for some aesthetic reasons, they might need an upper blepharoplasty. There's also functional reasons. People can have restricted vision because of their upper eyelid droop. They can get headaches throughout the day from raising their brows or complain a lot of a tired or heavy feeling at the end of the day. Blepharoplasties can be covered by insurance for these functional reasons, but a visual field defect has to be documented in order for that insurance to occur. It's really important to understand exactly what's bothering your patient and driving them to come in so that you can make sure that you address their concerns and have similar expectations for the outcome. So why has this become the most popular surgery over time? Well, the unique anatomy of the eye, which we will shortly get into, leads to some common age-related changes. For one, just as in other parts of our face where we have increasing laxity and soft tissue loss with age, this occurs in our eyelids, and it leads to descent and deflation of tissues there, just as it does everywhere else in our face. There's often some acquired brow ptosis that contributes as well to the heavy appearance of the upper lids, and this is especially prominent in the temporal region. This is because the temporalis muscle does not extend to the tail of the brow, and frontalis elevation becomes weaker with age. It's really important to notice patients who have brow ptosis, which is contributing to their heavy upper eyelids, because they may need a brow lift in addition to the upper blepharoplasty to achieve the ultimate cosmetic results. Dermatochalasis is the fancy term for baggy eyelid skin. This occurs because of the extremely thin skin of the eyelid, paired with the constant movement of the area from the blinking. And finally, the orbital septum, which retains our orbital fat, can attenuate over time, while the orbicularis muscle also becomes more lax. This also leads to an anterior prolapse of our orbital fat and gives a heavier look to the upper eyelid, and it can worsen the appearance of pre-existing dermatochalasis. So now we'll take a closer look at the anatomy, and here we're looking at a sagittal view through the upper eyelid and the orbit. We'll start from the outside with the skin and the subcutaneous tissue. So eyelid skin, as you all know, is the thinnest in the body. It's less than 1 millimeter, and there's no subcutaneous fat. So it's directly opposed to the underlying orbicularis oculi. Because it's so thin and there's constant movement, as we discussed, there's a high propensity to have skin laxity, extra skin over time. The tarsus, or the tarsal plate, is a dense plate of connective tissue that supports the meibomian glands and also provides structural support for the eyelids. This tarsal plate firmly attaches laterally to the periosteum via the canthal tendons, which are not shown here. The orbicularis oculi seen here is the main eyelid protractor. It's innervated by cranial nerve 7. As we all know, the contraction narrows the eye opening and causes the crow's feet. This muscle is divided into two portions. The pretarsal portion of the orbicularis oculi lies anterior to the tarsal plate, and it's very firmly attached to the underlying tissues. The preseptal portion lies anterior to the orbital septum, and it's more loosely attached to the underlying tissue. And this loose attachment right here leads to a potential space which over time can accumulate fluid and fat. So I let's get to the orbital septum, which is the thin fibrous tissue which arises from the periosteum of the orbital rim, and it lies deep to the orbicularis fascia and it retains the orbital fat, which is seen right here. At some point down here, the orbital septum fuses with the aponeurosis of the levator muscle, and this creates the anatomic boundary between the eyelid and the orbit called the supratarsal fold. I placed a red star here so that you can see that. The fusion is usually about 5 millimeters above the border, the superior border of the tarsal plate in Caucasian patients, but tends to be lower, somewhere around here in Asian patients. And that difference often leads to the single eyelid configuration that can be seen more commonly in patients of Asian descent. The orbital fat lies posterior to the orbital rim and anterior to the levator muscle, which lies here. That's called the pre-aponeurotic fat because it's anterior to the levator aponeurosis. If we look at a frontal view, we can see that there's 2 fat pads in the upper eyelid. So the main one is the central fat pad located here, and then medially, there's the medial or the nasal fat pad. The central fat pad can be seen in dissection as being more yellow in color, while the medial or nasal is whiter, and this is due to a difference in beta carotene levels. On the lower eyelid, which we'll just discuss briefly, there's actually 3 fat pads. So in addition to the nasal and the central, there's also a temporal fat pad. Very important to note that there is no temporal fat pad on the upper eyelid. If you see something lobulated and white appearing, you don't want to touch it because it's actually the lacrimal gland and you don't want to get into that. It's also important to note that all of these fat pads have direct connection with the retrobulbar space, and there's some large arteries that separate in between these two. Bleeding is one of the biggest complications that we're trying to avoid during any type of blepharoplasty when we're accessing the pre-aponeurotic fat, because some of that bleeding can go behind the orbit and lead to pressure that can cause some blindness. So very important, especially if you're accessing any of these fat pads, to control bleeding as much as possible. Next, we'll discuss the levator palpebrae superioris. This muscle originates in the apex of the orbit. It's innervated by cranial nerve 3, and it's the major upper eyelid retractor. Again, it's important to note that this lies directly below the central fat pad, so you want to take care not to injure this during any dissection of the pre-aponeurotic fat. The levator aponeurosis is the anterior and inferior extension of the levator muscle. It's usually 14 to 20 millimeters in length, and it's divided into anterior and posterior portions. The anterior portions insert, as seen here, into the septa between the pretarsal orbicularis and the skin. And this helps contribute to that really close apposition of pretarsal skin and muscle to the underlying tarsus. The posterior portion of the aponeurosis inserts into the lower anterior tarsus. And if you get disinsertion down here, this can lead to ptosis of the eyelid. And in that case, you would want to send to oculoplastics to fix rather than do an upper bleph. So looking at White-Mills ligament, this is also known as the superior transverse ligament. This ligament arises at the transition zone where the levator muscle becomes the aponeurosis, and it provides sensory support for the upper eyelid and the superior orbital tissues. And finally, we have Mueller's muscle, which we all know. Mueller's muscle is a sympathetically innervated smooth muscle, which originates from the undersurface of the levator and inserts inferiorly on the superior border of the tarsus. As we know, this is responsible for just about 2 to 3 millimeters of upper eyelid elevation. And this is a muscle that we will sometimes target with aproclonidine drops for eyelid ptosis after Botox. So now we'll discuss external eyelid anatomy and how everything that we just reviewed translates to what we see when we're looking at someone. The eyelid crease functionally occurs at the buccal point where the fixated pretarsal skin meets the looser preseptal skin. Anatomically, it's formed by extensions of attachments of the levator aponeurosis through the pretarsal orbicularis muscle to the skin. Where this is located depends on the ethnicity and the gender of the patient. So in most Caucasian men, this crease occurs about 6 to 8 millimeters above the margin of the upper lid. In women, it's more often 7 to 10. However, in patients with Asian heritage, the eyelid crease might be lower, sometimes in the 4 to 6 millimeter range. The pretarsal platform is the amount of skin that shows above the lashes when the eyelids are open. In many common blepharoplasties, this is what patients are trying to increase their amount of. They want to get a little bit more pretarsal show so that they have a better aesthetic appearance. The upper eyelid skin fold is the loose preseptal skin and subcutaneous tissues that lie above the eyelid crease. Typically, this is what we're trying to remove with our surgical upper blepharoplasties. The upper lid sulcus is caused by contraction upwards of the levator muscle, and it pulls the skin crease upwards and causes that kind of hollowing inside the orbit. The depth of this depends on how anterior or posterior the brow is positioned, how prominent the orbital rim is, and it also depends on the presence of prolapsed orbital fat, which can kind of mask or cover the upper eyelid sulcus. So there are definitely differences in Asians, and that could be a talk in its own, so we'll just briefly touch on that. If we're looking at a frontal view of an Asian eye here on the left and a Caucasian eye here on the right, there are some differences. People with Asian heritage are more likely to lack a defined eyelid crease. They may be more likely to have low set creases, incomplete creases, or even multiple creases. They more commonly have an epicanthal fold. They more often have the appearance of puffy eyelids without having true exophthalmos, and they more often have entropion or inward folding of their upper eyelid. Well, why is this? If we look anatomically at a sagittal view of a Caucasian eye on the left and an Asian eye on the right, we see that there's a lower fusion point of the orbital septum here and the levator aponeurosis that's more common in Asian patients. This allows for a lower penetration of the pre-aponeurotic fat into the pretorsal orbicularis, and this can lead to the appearance of a puffy eyelid, as well as mask any kind of true upper eyelid sulcus that they had. Additionally, the levator aponeurosis does not penetrate as well into the pretarsal skin, and so they have a less pronounced or a lower or sometimes even an absent eyelid crease. Again, the combination of these two things can lead to that appearance of a single eyelid in many Asian patients. Because of these differences in ethnicities, if you are discussing a bleph with an Asian patient, you want to make sure that you know whether they want to keep kind of their God-given appearance or if they want to change it to have a more European or Caucasian look. That would determine how high up you're going to place your lower incision line, because that's what's effectively going to become your new eyelid crease. If they want a more Caucasian look, then you'll be putting that in the 8 to 10 millimeter range. If they want to kind of maintain what they were born with a little bit more, just remove some of the extra skin or some of the extra fat, then you would keep that more in the 4 to 6 millimeter range. But again, all of that varies patient to patient, and that's kind of where a lot of the art of the surgery comes into play. So we'll get into what we do and how we see all of our patients. When someone's decided to have a blepharoplasty, they have at least an hour-long preoperative appointment, at which time we go over all of their history and physical exam and a review of the procedure and sign all their consent. So I'm just going to highlight a couple things that are important to note. So for the history, again, it's really important to understand the patient's true complaint as well as their goals and their expectations. And you want to make sure that in that sense you're aligned. It's really important to have an up-to-date medical history and especially an up-to-date medication list. As I mentioned, bleeding is one of your most concerning complications in a blepharoplasty. And so you want to make sure that patients are avoiding any medications or supplements that have anticoagulant properties. We recommend that these be held for at least 7 days prior to surgery. And this is especially important in anyone who you anticipate needs removal of fat pads, because the worst case scenario of bleeding in someone where you just do a skin and muscle excision is a black eye. But the worst case scenario if in someone that you remove the fat pads is blindness. So we review all of the medications with patients, make sure that they're not taking any of these. So another thing that's important to note in your pre-op appointment on history is whether they have any history of high blood pressure, because high blood pressure during the surgery as well as after the surgery can lead to increased risk of bleeding complications. Some patients won't have any a history of blood pressure, but they do have labile or hypertension or white coat hypertension. And so we do have medicines on hand to give patients intraoperatively if needed to control their blood pressure. And for those who are on blood pressure medications already, we instruct them to take their medicine the morning of, and we keep it monitored throughout. It's also really essential at this time to review any history of prior eye surgeries and especially a prior history of dry eye that's symptomatic enough that they need to do treatments, like they've had plugs put in or they use a lot of lubricating drops. Dry eye is already a risk of any type of eyelid surgery, and it becomes more of a risk if they've had other surgeries prior or if they already have a history of dry eye. You want to make sure that you're aware of that, and that if that's the case, that you plan, at the very least, a more conservative excision to minimize that risk. We go through a physical exam, which includes an examination of the heart and lungs, and we get resting pulse and blood pressure to make sure that they don't have any hypertension that we don't know about. We stress to our patients that we want them to have had a visual acuity testing and fundoscopic exam within the past year, that any pre-existing deficits that even might be subclinical to the patient are noticed. So we then use a paper chart to make notes of our patient's more focused exam, and we use this chart on the day of surgery to remind us of things that we noted. So we always start by assessing brow symmetry, especially the presence of brow ptosis or any temporal droop, as well as the compensatory use of frontalis for brow elevation. These might be indications that the patient will require a brow lift in addition to blepharoplasty, and you'll want to make sure to note that to your patients. At this point, very important that you make note of true eyelid ptosis, as this would not be corrected with blepharoplasty alone, and again would require kind of more of an oculoplastic surgeon. So important to note the strength of the glabellar and forehead muscles to make sure that everything is kind of functioning symmetrically. At this point, we look at, assess, and kind of push on the upper lid to assess or guess if there's any orbital fat that's going to be removed. We mark it as 1+ or 2+ or 3+ based on how much that we think is there, so that once we've got the anesthetic in during the procedure, we're able to go remember that we need to go and look for that. We always assess tear production, and that's usually just with a kind of a quick visual test, and especially eliciting a history of any dry eye from patients, and I will discuss that more in just a little bit. You want to look at the appearance of the sclera and conjunctiva to make sure that there's no pre-existing scars, and then we always perform a snap test for kind of skin elasticity on the lower eyelids. If patients have a poor snap test, especially when you're doing a lower blepharoplasty, this is a sign that lag ophthalmos or the inability to fully close the eyes may occur. At this point, another critical step is to assess if the patient has exophthalmos or kind of especially protuberant eyes for other reasons, such as a recessed orbital bone. Both of these scenarios require more skin for the eyelid to go over and fully cover the orbit. And so you might need to have a more conservative excision in order to have those patients fully close their eyes. Finally, you want to assess the range of motion of the extraocular muscles and the shape and the position of both canthi. Sometimes ancillary testing for dry eye can be done, including a Schirmer tear test, but typically we assess this through questioning in the history. And there are some studies that show that there's not actually a good correlation with people who have postoperative dry eye and patients who've had a normal Schirmer tear test prior to blepharoplasty. So we then make some rough estimations of the redundant skin that's going to be removed during surgery. So with the patients upright, we have them close their eyes and we manually elevate their brow until all laxity is removed and their eyelashes are standing about straight up. We take the measurement from the eyelid margin to the brow in the mid-pupillary line and subtract 20 millimeters, and that's a rough estimate of how much skin will need to be removed. In general, you need to leave 20 millimeters for patients to be able to cover their eye, but again, it could be more in patients who have a very high pretarsal platform, who have exophthalmos or really protuberant eyes, very large appearing eyes. You need to be aware that they might need more left behind. So what are the contraindications to upper bleph? We've discussed some of them. If someone's already got a severe ocular comorbidity, they've had multiple surgeries, they're more at risk for complications after an upper bleph. If they have severe dry eye, another contraindication, or at least a relative one. Uncontrolled hypertension just really increases your risk of postoperative bleeding, bruising, swelling. If a patient has an underlying bleeding condition or is on anticoagulants, and then importantly, if a patient has unrealistic expectations. So we'll get into the fun stuff, which is the surgical technique. I do want to note that it's quite varied from surgeon to surgeon. So I am going to detail kind of what we do, and then I will make some brief asides into alternatives. So the first step is really marking the step, and in our practice, this is by far the most important step. We really take a lot of time doing this. We measure multiple times to make sure that we really get it right. And there's various techniques to do the markings with, and I'm just going to show you the one that we've that's kind of been perfected at our practice over time. So we first prep the skin. We clean it with acetone to remove any grease and make sure that our marks stay on and don't smear because they need to be really precise. We use calipers and forceps for precise markings. We use fine tip Sharpies for marking, and we add gentian violet if a lower bleph is also being done on the same day, and this helps make our marks more durable. And then it's important to blot with gauze each time you make a mark to, again, prevent it from smearing or bleeding. So this is a photo of our typical marking tray. We've got our calipers here. We've got some forceps so that we can pinch the skin. We've got our markers, a little acetone, some CTA to clean things off, and some gauze. Pretty straightforward. For our skin marking, we like to place the patient in this supine position, and you need an assistant to help you to do these markings. So in the mid-pupillary line, we have an assistant stretch the upper eyelid as high as possible while the patient keeps their eyes just closed. The brow should be elevated just to the point of eyelash aversion without actually opening the eye. So you want to get all the slack out that you possibly can, but not open that lower eyelid at all, or the eyelid at all. At this point, in most patients, in most white female patients, we would mark a dot that's about 8 millimeters above the highest eyelash line on the upper eyelid, and this is in the mid-pupillary line, okay? In men or Asians, this can be lower, and in patients with a very tall eyelid platform or very large eyelids, it may actually be higher. So again, this is some of the kind of skill that you gain over time, is just determining how to manipulate your marks from patient to patient. We then use a wooden Q-tip applicator to measure the distance from the medial canthus to this mark, and then we replicate it on the other eye and make sure that we're again at 8 millimeters or whatever measurement we've decided from the eyelid margin on that side. Here's a picture of us stretching the skin, getting all the slack out, and making our initial mark at about 8 millimeters in the mid-pupillary line. Next, we place our medial mark, and you want to be about 5 millimeters above the halfway point between the innermost eyelash and the medial canthus. If you get closer to the medial canthus or you get too inferior, you increase your risk of scarring and canthal webbing, which is not a good outcome. So typically, placing it halfway between this eyelash and the medial canthus and 5 millimeters directly above, you're in a safe zone. Then the lateral mark is placed, and this is for also the lower incision line. The lateral mark is placed in the major crow's foot as far laterally as to be in a vertical plane with the tail of the brow. And it's really important to go that far laterally, and especially in older patients who do have a lot more of that temporal hooding, so that you can catch that extra skin fold that's really hanging down and bothering them. However, in patients who are younger, who don't have as much temporal hooding, or who don't have really prominent crow's feet, you may actually want to move that a little bit closer to the lateral canthus so that you minimize the appearance of the scar. So the line of the lower incision in general should kind of follow a very smooth and gentle curve along the kind of back side of the orbit. You can always double check that you're somewhere between 6 and 10 millimeters in the mid-pupillary line above the eyelashes, somewhere about 5 on the lateral and medial marks. So then we make our superior mark. So The superior incision line should reach its apex in the mid-pupillary line, and this is always the first mark that we make. It needs to be high enough that you are removing enough problematic lax skin, but low enough that you're leaving enough skin between this mark and the brow that the eyelid can close all the way. And usually the teaching is that you need to leave at least 10 millimeters between the skin-brow junction and this mark. However, again, there's always special cases where that's not the case. As you can see in this video here, we use some forceps to gently pinch on the skin from the lower incision point to determine how much skin can be removed without changing at all the position of the eyelashes. We mark this point, we measure it with calipers, and then we transpose it onto the other eye. Once you've done this, it's really important to check both eyes that the skin can be pinched without raising the eyelashes at all. In most of our cases, we're taking the same amount from both eyelids. However, there are times when a mark on the contralateral eye will need to be adjusted higher or lower, either because of asymmetric brow position or differences in skin laxity between the eyes. But you always want to be assessing for any small adjustments that need to be made. There's that video again. So then we connect the dots. And again, the upper excision line should be drawn as a smooth arc, which is highest in the mid-pupillary line, and you should be able to pinch all along this arch without raising the eyelashes at all. A slight inward sweep can be added for patients who have excess medial skin, and you want to, again, keep this lateral portion of the excision a little bit higher in patients who do have more of that temporal hooding. Next, you want to double check everything. You want to assure that you're symmetric between eyes. In most cases, same amount of skin is being removed, and then double check all along the arc, as I just mentioned. So next, we will move on to anesthesia. So our patients get a cocktail of oral sedation prior to the procedure. So we give them a Phenergan an hour before to minimize nausea from the narcotics. We then give a Percocet and Valium about 30 minutes prior to the start of the procedure. And all throughout, we have pulse ox, heart rate, and blood pressure monitoring. We typically use 3 to 5 cc's of mepivacaine with epinephrine, and we find that there's less resistance to mepivacaine than lidocaine, which is why we switched. We inject the eyelid very superficially to reduce any bleeding and hematoma. And important when you're injecting around the eye is to stabilize your injecting hand on your patient so that even if you move, you know exactly where your needle is and it's not going anywhere that you don't want it. We, over time, have started injecting extra anesthesia at the lateral margins of our incisions and just above it, as we found that there's some small vessels in these locations that are our most common sites of bleeding when we're doing the skin and muscle excision. We then gently disperse the anesthesia by rolling a cotton-tipped applicator back and forth on the eyelid with the supraorbital bone as a backing. And we allow the anesthesia to set for 20 minutes so that we've got the best hemostasis possible. Then we put in our topical proparacaine and tetracaine drops to the eyelids for numbing before putting in the corneal shields. So this is just a photo of our patient being numbed after being marked. We're really messing up that lax eyelid skin as much as possible while keeping our tip really superficial and balancing our hands right here. So this is an image of the surgical tray and the tools that we use. So starting on the bottom, we have 2 pairs of Bishop Harmon forceps, one that has teeth and one that doesn't. Next, we have a large retractor and then a small retractor right here. These are used during dissection of the fat on the upper eyelid to kind of pull back some of the skin and expose the fat, and you'll see that shortly in a video. Between the two is our Castro Viejo needle driver, and this has a really fine clicking mechanism to open and close and allows for excellent rotation of your wrist while you're suturing. On the far right, we have this shield, which is used to protect the skin from any overshoot of the laser beam. We have curved iris scissors, a skin hook, and a hemostat, and those are all used for kind of suture cutting and also for keeping some tension on the wound while we're doing some suturing. And then our sterile laser tip is right here at the top, as well as some sterile water, in this case some betadine, cotton-tipped applicators, our suture, and sterile gauze. So before diving straight into the videos and technique, I wanted to discuss some of the controversies within the field of blepharoplasty. And the main ones are, is it better to use steel or laser? And should you remove part of the orbicularis oculi during surgery or leave it intact? So what are some of the advantages to using a laser over cold steel? Well, there's no need to stretch the skin out because the laser is just so precise. You don't need any tension on that. The laser coagulates as it cuts, and this helps improve the visibility of the surgeon. And there's also studies that demonstrate that it reduces procedure time and that it leads to less postoperative bruising and less swelling. We also really like the ability to defocus the laser and deliver heat to the tissues, and this can help with tightening tissues and kind of shrink wrap it up. So there's been a couple studies on this. This is one from 1992, which compared in a split face trial, surgical blade versus light, and found that with laser, there was reduced operating time, less bleeding, bruising, and swelling, and a shorter recuperation time with the laser. Another split face trial was done in 2003, where they just did the skin excision with either laser or cold steel, and then did all of the kind of subcutaneous dissections with laser. And in this case, they showed no significant difference in overall outcomes of swelling and bruising, or in the final scar outcome at 60 days. There was no significant difference, but there was a trend towards a better scar outcome in the laser cutting group. More recently, there's another technique or another method of cutting. It's called a Colorado needle. It's kind of a micro needle that uses electrocautery to cut rather than laser. So this study, they looked at patient and physician aesthetic outcomes and found that they were the same. However, in this case, the Colorado needle had a shorter procedure time than the laser, and on histology only, it showed less thermal damage, but there was no clinical difference in thermal damage from the scar. So my takeaway from these studies is that the laser can speed up the procedure time, and it can make healing a bit faster with much less risk of like a black eye or a lot of swelling. However, the final aesthetic outcome is much more dependent on the preoperative planning that you do and the technique of the surgeon than on the instruments that are used. So what are the disadvantages of the light? Well, there's a few. So one is that the equipment and the maintenance of the equipment is more costly than just using a regular scalpel. It requires two assistants because one is necessary to evacuate smoke while the other is kind of assisting surgically. And most importantly, it requires the physician performing the surgery to be an expert in laser surgery as well as surgical blepharoplasties. So the next debate is whether orbicularis muscle should be removed during the surgery or left behind. The traditional teaching was that both skin and muscle should be removed to achieve more debulking of the tissue. And it's also a bit easier to just raise them at the same time because they're so closely opposed. There's no subcutaneous tissue or fat there. More recently, there's been a shift towards removing the skin only and leaving muscle behind. And this is because there's a concern that traumatizing or removing some of the orbicularis will lead to difficulty with closing the eye, and that can then lead to exacerbating dry eye and, you know, in worst case scenario, some corneal scarring. At this point, as far as I can tell, this is more of an issue of dogma than anything else, as there's really few studies that have been done that show any difference. I did find one study which detailed one surgeon's outcomes on a split eye study done on 20 patients over the course of 27 years. And his study revealed identical aesthetic postoperative results, but showed a trend towards increased dry eye and lag ophthalmos in the side where it took muscle as well as skin. However, this was all in the kind of immediate postoperative period, and in most cases they were resolved. There's obviously some disadvantages to this study in that it was a single surgeon and a small sample size. And additionally, clinically, we do see some kind of short-term postoperative lag ophthalmos, which is likely due to swelling and trauma from injuring the tissue, but this tends to self-resolve. So in our practice, we do take muscle. We find it gives more effective debulking and find that the incidence of lag ophthalmos and dry eye is mostly avoided with extremely careful marking and a more conservative operation in patients with pre-existing eye conditions. I've also pulled some other oculoplastics and plastic surgeons that I know who do this procedure. And as far as I can tell, the results are kind of all over the board, and probably more studies need to be done to determine if there's really a true difference in the long run. So now on to the fun stuff. For most of our surgeries, we use a CO2 laser. We often use the luminous ultrapulse laser, and sometimes we use a fractal repair laser. We have a 0.2 millimeter cutting head for both of them. For our initial skin incision, we use the ultrapulse mode at 200 pulses per second. Our thinking being that the short breaks in between rather than a continuous wave minimizes the char on the surface of the skin and minimizes that thermal damage to the skin. The wattage that you choose depends on the speed of the surgeon, as a higher wattage will cut more deeply and more quickly. We tend to use 10 watts. And then after the skin incision, every other part, the laser is switched to a continuous wave mode at 10 watts. In this mode, or in both really, the laser can be focused in very tightly for kind of more precise cutting, and the beam can be defocused for coagulating or tightening, and you'll see some of that in our videos. So I'm going to share a video, but before I do that, I wanted to make a few comments. So by this step, the skin has been sterilized. We've inserted sterile corneal eye shields, and we've got a sterile drape applied. And we typically remove the skin and the muscle together as a single flap. The alternative would be to remove the skin first and then the muscle. And this is really one of the most technically difficult parts of the procedure, is to be in the right plane during that dissection. When you're making your initial skin cut, the laser should be kept as perpendicular as possible so that you don't bevel your wound edges and end up with more of a mounded scar at the end. So here is the video. I'll get started. So we've marked, we've made them numb. We've already actually cut the lower incision line. And here we're using the laser, and we're trying to make a smooth arc incision, keeping our laser as vertical as possible. We go to the end. After that, we're using our Bishop Harmon forceps. We're on a continuous wave mode now, and we're kind of up close to cut. We are pulling up with our Bishop Harmons, and we're keeping our laser horizontal so that we keep our cut right in the right plane. So the goal that you're going for here is to be able to see the fibers of the orbicularis as you're pulling up, which it bleaches out a little bit with like the lighting, and then you should be able to see the orbital septum below, which is more white in color, may have some vasculature, and also can have some fat globules occasionally. So here we are, we're removing the skin muscle flap. There's both skin and orbicularis through there. So here we are at this point where we have removed the skin and the muscle. And what you're left with here is the orbital septum. So as we know, the orbital septum comes from up here, and then somewhere down here it fuses with the levator aponeurosis and then inserts itself into the orbicularis and the tarsus. So at this point, we defocus our laser beam and we tighten up the orbital septum a little bit, and importantly, we coagulate any bleeding vessels. As you can see, we've got a really clean surgical field. We've got minimal bleeding. If we do have a little bleeder, we can defocus and coagulate it. So it's a quite clean procedure. The next step in this patient was to remove the preaponeurotic fat. So we lift up on that orbital septum and we create a little window through which we can access the orbital fat. So we've made the window. We're going after the central fat pad right here. We've got our retractor there to protect the skin against any laser overshoot. And we're going to extend our window a little bit laterally and medially. So at this point, this is a critical step because, again, there are blood vessels attached to this piece of fat that go all the way back behind the eye. And so we handle this very gingerly. We never pull up on the fat. We never yank on it. We never drop it back down. We're actually applying pressure right here to the globe so that the fat herniates itself outwards. And then we never shoot down into this region because obviously we've got muscles, the levator, the back of the orbit down there. We're only taking fat as when it comes above the orbital septum, and we're picking it up very gently and just transecting it at the base. So you can see that here, really gently picking it up. Again, we're using that continuous wave mode at 10 watts, and we are gently transecting at the base. We also always double check both sides of the fat, and we make sure to coagulate any blood vessels that are there before so that we don't inadvertently cause some bleeding while we're doing this. So hemostasis is a critical part of the procedure. So we've got some of the central fat pad. There's a little bit more that's popping out. So we just really gently grab it, help it out, and then transect it at the base. So after this, we'll go for our medial fat pad, which both of the fat pads are kind of enclosed in their own little capsule. And so here we're removing a little bit more orbital septum and going for the medial fat. In a lot of cases, it's a little bit paler or more white looking, though you couldn't see it as well there. So at this point, we've removed all of our fat, and then we're going back. We're double checking that we don't have any bleeding. And again, we're doing just a little bit of tissue tightening by using our defocused laser beam. And you can actually see the tissues tightening right before your eyes. So at this point, you're done with your upper blepharoplasty. Our next step is to remove this laser tar that's been left behind. We take some sterile Q-tips, dip them in sterile water, and kind of very gently scrub off that edge so that it's not going into our suture line. So we'll move on to the skin closure. So we use a 6-0 dermalon suture and a running vertical mattress stitch. We always start from the medial canthus. This is my little drawing here. It's really important to keep all of your suture lines vertical. So in a lot of cases, that means that you're taking a lot, because the arc on the top incision line is much steeper and longer than the lower incision line, you're moving over more farther on the top incision line and less on the bottom. And this helps keep your stitches totally vertical and prevents any bunching due to the differences in length in the two sides that you're stitching together. We also keep all of our bites very, very close to the skin edge. If you get a little bit farther away, then you get too much of a rolled border, which will eventually settle out, but just takes longer to heal, and patients are more happy if their scar looks better from the get-go. And again, keep all your stitches very vertical. How do we do that? So here we've made our initial knot in the medial canthus. We've got a hemostat attached over here outside of the field of view to keep some pressure. And then we've got a skin hook into the lateral part of our incision to also keep tension there. We've started making our first few up and down, and then we are stitching the rest of the way. Let's see, right here. So we're using our Castro Viejo needle holders, putting it through and going along our merry way. All right. So our postoperative care, all of our patients who have a BLAF are monitored for 1 to 2 hours post-op. It's a longer monitoring period if they had hypertension, if they bled a lot, and especially if we access any of the orbital fat pads, because we want to make sure that if any bleeding occurs, we catch it early. Also, to minimize bleeding, we have them ice, recline, and elevate for 48 hours. That means pretty much throughout the day, they are iced and reclined unless they're eating or they're going to the bathroom. We have a clindamycin 0.5% ointment that's compounded in plastibase, and we have them really gently apply that to their suture line. Any infections are pretty rare. We really firmly counsel them on not touching or rubbing or bumping or sleeping on those for 2 weeks. We don't want the stitches breaking open. We want them doing light duty only, no working out, no bending over, and that's for 2 weeks. No contact lenses for 2 weeks, and then their sutures come out in 7 days. So what are the complications? Well, if you look at studies, the majority of complications are cosmetic, and they reflect a dissatisfaction with the appearance of the final eyelid. And this is part of the reason that discussing the expectations and doing some really meticulous surgical planning and execution are critical, because by doing that, you can avoid a lot of those headaches. Vision loss, luckily, is very rare. There's about a 0.04% incidence, but it can occur because of ocular injury, extraocular pressure, or orbital hemorrhage, which we've mentioned. We always, of course, use an ocular shield to prevent any ocular injury from the laser, but this is why it's critical to manage blood pressure and intraoperative bleeding and make sure that patients are able to get a hold of you if they start noticing more bleeding on one side than the other, more bruising on one side than the other, more swelling. So regular amounts of bleeding are common, and occasionally patients will have a black eye. It's more common with cold steel surgery than with a laser. We get about 1 a year. But again, most concerning if you did access the preaponeurotic fat, because you can get retrobulbar hemorrhage. So if a patient does present with unilateral swelling, bleeding from one side, if they have proptosis, if they're not able to do all their extraocular movements, they have a poor light reflex, change in vision, you need to take immediate action with a lateral canthotomy, do exploration and hemorrhage evacuation to preserve their vision, but that is outside the scope of this talk. Orbital cellulitis is a very rare complication, but in patients where it does occur, you have to also rule out any retroorbital abscess, which could have more serious implications. Scarring issues can occur, so sometimes you'll have dehiscence of the suture. Occasionally, patients will have hypertrophic scarring. They can have a little bit of milia formation along their scar line. Often these are improved with minor revision or some fractional non-ablative lasers or kind of removal or expulsion of the milia. Cancel webbing is a concern, but it can be avoided again with meticulous planning and closure, making sure that you're not putting that medial mark too close or too inferior to the medial canthus. Corneal irritation is relatively common, a mild degree in most patients post-operative. So we recommend that all of our patients do topical lubricants, but you always want to have a low threshold of suspicion for a corneal abrasion or ulceration and make sure to treat those promptly if they do occur. Swelling and bruising are very common, It's really variable between patients how long they stay swollen for. Some people look perfect after a week, and some people hold on to a little bit of swelling for like six weeks. Lag ophthalmos, or the inability to totally close your eye, can be seen in the immediate post-op period, probably due to some of the injury to the muscle and just to the swelling from the procedure, but it often resolves as long as the surgery was properly planned and performed. So again, if you plan to take out way too much, then they're not going to have enough skin left to close their eye. And of course, there's laser-specific complications that can occur, such as burns, a loss of eyelashes, and then a fire risk. Exacerbation of dry eye can be a more prolonged issue, and this can be seen after any kind of eye surgery, including LASIK. But if it's severe, it can lead to corneal ulcers and scarring. Again, we avoid this with proper patient selection and with conservative and careful skin marking and planning. So dry eye, as I mentioned, can sometimes be hard to predict. So because 65% of patients who go on to develop dry eye would have actually had a normal preoperative Schimmer's test for their tear production. So some authors came up with some other clues to predict patients who might have dry eyes, and a lot of it has to do with their anatomy and what we talked about, which is how protuberant appearing are their eyes. So clues that someone might develop dry eyes, or if they have relative or real proptosis, if they have exophthalmos, and then sometimes you get a dry eye or lag ophthalmos because your lower lid is not able to rise enough. So if someone has hypotonia of the lower lid, or so poor laxity, if they have maxillary hypoplasia, or if they have inferior scleral shell, that's another hint that they've got kind of poor elasticity to their lower eyelid and might not be able to close their eye all the way. Other medical risk factors for dry eye would be any prior refractive corneal surgery, a history of diabetes, a smoking history, and then also if they've got any bleeding disorders or anticoagulation. Well, that pretty much concludes my talk on upper blepharoplasty. I wanted to thank Dr. Taylor, everyone at Gateway, and Hannah for setting this all up. It's been fun to do this, and I would be happy to answer any questions at this point.
Thank you. You can unmute and ask your questions, or you can type them in. If there are no questions at this point, oh, something came in. Oh. I think we have Dr. Taylor on the online as well. I don't know if he can unmute, and does he have any anything to share with the group, or?
Yes.
Yeah, that'd be great.
Nice job, Dr. McClean. Excellent. So we've done several thousand of these, and so these principles work really well for us. We realize that there are other methods and other options that can be used, but we've refined this over 25 years, and it works extremely well for us. And so those principles that Dr. McClean talked about have been tested and tried over many years in the field, and work really well. The hardest part is designing what to do and being able to recognize the anatomy of the patient and any pitfalls that you may need to deal with. So that's where experience comes in, and you know, being able to make sure you're designing it so it looks good and functions well.